how do you think, how could we identify which kind of myocardium is at risk in the future? Maybe this patient might need intervention causing the angina, ischemia burden. What do you think?
Well, we know as we proceeded with the field that all the imaging modalities are improving a lot. And structural interventions, particularly structural heart disease, is very, very important. The imaging factor or the images and the techniques from echo to MRI are extremely important. They improve not only the results, but also the patient selection, as you indicated. And maybe while we're doing this, we can identify patients that we should attack earlier, much rather than later, before the damage comes into the myocardium and before it gets irreversible. That's why we're moving forward to asymptomatic patients or moderate aortic stenosis, and we'll see what the results will be. We will see the very first results in New York Valve in about 3 weeks. The first carefully selected patients and the first trial results will come out. So we are excited to see the results coming out. And I'm sure as we move along, we will have a better way of identifying those patients that are at risk, and we have to tackle those earlier.
Yeah, so according to the EuroPCI data, we know that routine PCI might not be needed, but also there was article meta-analysis telling us that maybe we can perform FFR to decide whether to perform the PCI. Is it possible to use other image modality like CT, like maybe fat attenuation, this kind of feature? Is it possible?
I think, of course it's possible. And I think it will be used more. As you know, now CT angio of the coronaries, I shouldn't say replacing catheters, but in the early diagnosis, we see more CT angios are being used now in order to identify the patients at risk and the patients that might need some intervention. I personally believe that we will not have an answer by studies whether we should do PCI together before or after. It depends on the valves. It depends on the experience of the site. It depends on how difficult the lesion is, how risky the lesion is. What you don't want to do is you don't want to add risk to TAVR by doing a procedure at the same time. If you believe, based on your experience, that you can handle this fairly quickly, then maybe you should do it in one session. But that's individually tested in each institution depending on their experience.
Oh, that's a very good point. So let's move on to mitral and tricuspid valve. How about because nowadays we are doing M tier, T tier, and then nowadays we also have new Lux valve, and is it possible that we will use this transcatheter mitral or tricuspid valve replacement instead of the tier?
Well, this is a topic in itself. I have to say, this will not be as successful as we have been in TAVR. Both mitral and tricuspid is a totally different animal. My personal opinion is that we will not, I think we are not living in our own world. As intervention cardiologists, we tend to do things that we can do. And we know we cannot do repair very well. We do have T tier and M tier, but those are not causing or healing of the root cause of mitral insufficiency. It's a palliative procedure, which is very safe. So M tier and T tier definitely will stay, but it's not a solution to dealing with mitral insufficiency. And much less it is a solution to come out now with saying, okay, then we replace. Because replacement is an artificial heart valve with all the consequences, all the problems, and even those we're not as good as the surgeons. So here we go. We have low flow areas, we have degeneration, we have paravalvular leaks, we have pacemaker issues on the right side. So we have a lot of issues on the replacement side. The most important thing, and that's what the protagonists say, we abandon mitral insufficiency. But the surgeons with good technique, they can do repair and abandon surgery. We simply can't do it. We cannot do it on the mitral side, and we cannot do it at the tricuspid side. So in order to put this into perspective, what are our treatment options? Surgery here, replacement 15% on the right side for patients that have either extreme risk or that could not be treated with MTR. Then you might consider replacement. But it's not a big market. And the TR is there because it's safe. Everybody wants to do it.
Yeah.
But we also know these patients will be coming back. And then what we do then? So I think the future will be replacement will be there. Definitely MTR will stay, or TTR for that matter. But we have to look at out-of-the-box solutions, and we have those now. We presented the early data on out-of-the-box solutions, replacement, enhancement of the posterior leaflet. On the right side, it's a different animal. We have TTR, and we have very successful valves. But before you implant an artificial valve, you should really explore things very carefully. I'm not cutting down replacements, but I think we have to put it into perspective.
Thank you so much. You have spoken about the skills. So it's truly an honor for us to learn all these skills, all these advanced skills from you, the very best of this area. And we hope to see you again next year.
Thank you.
To learn more from you.
Thank you very much.
Thank you so much.
Appreciate
It's a great
it.
honor.
Thank you very much.
Bye.
Bye-bye.